Hello everyone, and welcome to 𝘵𝑚𝑒𝑡𝐴COCCUS video series where we'll explore some high-yield USMLE Step 1 recall questions. Our goal is to break down these challenging topics, focusing on the key concepts that the NBME loves to test. Whether you're brushing up on your knowledge or tackling these questions for the first time, we're here to guide you through the details that matter most for your exam. Let's dive in and make sure you're fully prepared for whatever comes your way on test day. In this first case, we have a 22-year-old woman who comes to the emergency department with a severe left frontal headache that has been recurring daily for the past 3 days. Each episode resolves on its own after about an hour, and on physical examination, the patient appears to be in significant pain and has ptosis on the left side. The episodic nature, the unilateral severe pain, and the ipsilateral autonomic symptoms, in this case ptosis, are classic features of cluster headaches. Cluster headaches are characterized by rapid onset of severe unilateral pain that typically involves the periorbital or frontal regions and is accompanied by autonomic symptoms, such as ptosis, meiosis, and nasal congestion. These episodes last 15 to 180 minutes and occur in clusters, often at the same time every day. The presence of autonomic symptoms is what strongly differentiates cluster headaches from other headache types, such as migraines. Treatment of acute attacks is usually with oxygen therapy or triptans, while verapamil is often used as a preventive measure. Let's take a closer look at this table, which compares the 3 most common types of headaches: migraines, cluster headaches, and tension headaches. Each type has distinct characteristics, so it's important to understand their key differences. Starting with migraines, these are more frequent in females and often run in families, so a family history can be a big clue. Migraines usually present with a throbbing, unilateral pain that can last anywhere from 4 to 72 hours. Along with the pain, patients often experience sensitivity to light, or it's called photophobia, and sensitivity to sound, or phonophobia, and some may even have an aura beforehand, those visual or sensory disturbances that can serve as a warning sign. Now let's move to cluster headaches, which are actually our main focus here. These are more common in males, and unlike migraines, there's usually no family history involved. The pain is severe, and patients often describe it as ice pick-like, which gives you an idea of just how intense it is. The pain is sharp, unilateral, and typically located behind one eye. Cluster headaches come in bouts or clusters, hence the name. These episodes can last anywhere from 15 minutes to 3 hours, and often strike at the same time every day, sometimes even waking the person from sleep. You'll also see some unique autonomic symptoms like sweating, facial flushing, nasal congestion, and even changes in pupil size. These really set cluster headaches apart from the other types. Finally, tension headaches are the most common and tend to be more straightforward. These are usually bilateral and feel like a dull, tight band around the head. They often pop up in stressful situations and can last anywhere from 30 minutes to several months. Unlike the sharp pain of cluster headaches, tension headaches are more about a general sense of discomfort, often accompanied by muscle tenderness in the neck, shoulders, or scalp. In summary, cluster headaches are distinct due to their male predominance, unilateral ice pick pain, and the presence of ipsilateral autonomic symptoms like nasal congestion and pupillary changes, making them a unique clinical entity. Now let's dive into this next case. We have a 34-year-old man who's dealing with a particularly severe type of headache. He describes a throbbing pain concentrated around his right eye, and here's an important detail. It's been waking him up from sleep over the past week. The episodes last about 20 to 30 minutes each time, which already points us toward a specific diagnosis. He's also experiencing conjunctival injection, which is redness of the eye, and meiosis, pupil constriction, on the right side. During the physical exam, you notice that the patient seems extremely restless, even pacing, which gives you an idea of just how intense his pain is. This presentation is textbook for cluster headaches. As we mentioned earlier, these are much more common in males, and they present with excruciating unilateral pain, typically focused in the periorbital or around the eye region. A key feature is how these headaches occur in clusters, often at the same time each day, or even waking the person from sleep, as we see in this case. Cluster headaches aren't just about the pain. They also come with a whole host of autonomic symptoms: lacrimation, nasal congestion, drooping of the eyelid, and small pupils, which really help distinguish them from other types of headaches. Now what's going on at a deeper level? The pathophysiology involves the trigeminal autonomic reflex, which basically means there's abnormal interaction between the trigeminal nerve, responsible for sensation in the face, and the autonomic nervous system. The hypothalamus also plays a role here, particularly in controlling the circadian timing of these headaches, which explains why they often strike at the same time each day. It's also worth mentioning that this patient's lifestyle, specifically smoking and alcohol consumption, are well-known triggers for cluster headaches. These factors can either bring on an attack or make them worse, so they're important pieces of the puzzle when managing these patients. Next, we have a 40-year-old man with severe recurrent headaches centered around his left eye, accompanied by lacrimation and nasal congestion, is presenting with classic signs of a cluster headache. These headaches often occur at the same time each day and can last anywhere from 15 to 180 minutes. The key here is the sharp, excruciating pain, which is characteristic of cluster headaches. The patient is also at higher risk for cluster headaches due to several factors. However, the most significant risk factor is the fact that he is male. Cluster headaches are much more common in males than females, with a male to female ratio of approximately 3-to-1. While smoking and alcohol consumption are potential triggers for these headaches, they are not as strongly associated with the overall predisposition for developing cluster headaches as male gender is. Cluster headaches are classified as a type of trigeminal autonomic cephalalgia, and they are uniquely characterized by their episodic nature and the presence of ipsilateral autonomic symptoms such as meiosis, ptosis, and lacrimation. Understanding these key demographic risk factors, particularly the male predilection, is essential when diagnosing and managing this type of headache. Next, here we have another type of headache in a 22-year-old woman who comes to the emergency department with a severe right-sided headache following a visual disturbance. She describes a hole in her vision that expanded into a C-shaped visual disturbance in her peripheral vision, which spontaneously resolved after 15 to 20 minutes. Following this, she developed a pulsating headache. These characteristics are strongly indicative of a migraine with aura. Migraines are a neurological disorder that presents with severe unilateral throbbing headaches, often associated with photophobia, phonophobia, and nausea, vomiting. Up to 25% of migraine patients experience aura, a focal reversible neurologic symptom that precedes or accompanies the headache. The pathophysiology behind migraines includes a wave of depolarization that spreads across neurons in the cerebral cortex, activating trigeminal nociceptors. This woman's visual aura is a common manifestation, and it represents the spread of depolarization into the visual cortex. While migraines last 4 to 72 hours, the key differentiating factor here is the visual aura and progressively worsening headache, which is not present in other forms of headaches, such as cluster headaches or transient ischemic attacks. Okay, next. In this case, a 27-year-old woman presents with severe unilateral throbbing headaches associated with photophobia, nausea, and occasional vomiting. The patient's headaches resemble migraine headaches and have a familial component, as her mother also has a history of similar headaches. Over-the-counter analgesics have not provided sufficient relief, so the physician prescribes a medication to be taken at the onset of the headache. The medication prescribed is most likely a triptan, which directly addresses the mechanism of migraine through its action on the serotonin receptors in the trigeminal nerve. Triptans are serotonin receptor agonists that stimulate trigeminal serotonin receptors, inhibiting the release of calcitonin, gene-related peptide, and other vasoactive neuropeptides. This leads to intracranial vasoconstriction and a reduction in pain through the inhibition of neurogenic inflammation. By targeting the trigeminovascular system, triptans provide effective abortive therapy for migraine attacks. Let's move to another migraine case. A 26-year-old man presents with severe right-sided throbbing headaches accompanied by nausea and photophobia. The patient reports that these headaches began in high school but have become more frequent, significantly affecting his work. He currently manages the headaches with non-steroidal anti-inflammatory drugs, sumatriptan and metoclopramide for nausea. Physical examination and recent brain imaging were normal. Given his increasing headache frequency, preventive therapy is needed to reduce the severity and number of future migraines. The correct answer here would be topiramate, an anticonvulsant known to reduce migraine frequency. In migraine management, preventive therapy is initiated when the migraines become frequent or disabling, like in this patient's case. Besides topiramate, other preventive options include beta blockers, tricyclic antidepressants, and valproate. Abortive medications, such as non-steroidal anti-inflammatory drugs, triptans, and antiemetics, remain useful for acute symptom relief but do not prevent future headaches. The patient's current treatment addresses acute symptoms, but a preventive approach is now necessary to improve his quality of life and reduce headache occurrences. So, migraine preventive therapy includes medications such as anticonvulsants, topiramate, valproate, beta blockers, and tricyclic antidepressants. These medications are prescribed when migraines occur frequently or impact daily life. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.